Good morning, everyone. Today, we're going to delve into one of the most common yet often misunderstood conditions in gynecology. This is not just a story about a single bacterium, but about an ecological imbalance. Welcome to Gardnerella vaginalis, the key player in a complex dysbiosis. Our goal is to move beyond the basics and understand the investigative approach to diagnosing and managing bacterial vaginosis. Let's set the scene. Our typical patient is a sexually active woman. Her chief complaint is almost a textbook description: a malodorous vaginal discharge. It's often described as thin, grayish, and most characteristically, it has that distinctive, fishy odor. Here's a critical clue during the physical exam. Despite the discharge, there is a notable absence of significant inflammation, itching, or irritation. This lack of inflammatory signs is what separates BV from other vaginal infections like candidiasis or trichomoniasis from the very beginning. Our first diagnostic test is simple but powerful: checking the vaginal pH. In a healthy, premenopausal vagina, lactobacilli keep the environment acidic with a pH at or below 4.5. In bacterial vaginosis, this ecosystem is disrupted. Finding a vaginal pH greater than 4.5 is our first solid clue, a cornerstone of diagnosis. It signals a fundamental shift away from a protective, lactobacillus-dominated environment. Now, we look for the smoking gun under the microscope, the clue cell. This is not just any epithelial cell. It's a vaginal epithelial cell that has become so coated with adherent bacteria, primarily these small coccobacilli, that its borders appear blurred and stippled. The cell is literally clued in with bacteria. The presence of these clue cells on a saline wet mount is the single most specific microscopic finding for bacterial vaginosis. If you see them, you are almost certainly looking at bacterial vaginosis. So, who is the main suspect we see on those clue cells? Most often, it's Gardnerella vaginalis. Let's profile it. They are gram-variable coccobacilli, and they are facultative anaerobes. They thrive in the new, less acidic environment of the bacterial vaginosis-afflicted vagina. But, and this is a crucial but, finding Gardnerella alone does not equal disease. This brings us to the core concept we must understand. Gardnerella vaginalis is a key player, but it is not a solo culprit. Think of bacterial vaginosis not as an infection by a single pathogen, but as a synergistic polymicrobial infection. Gardnerella paves the way, but it acts in concert with other anaerobic bacteria like Mobiluncus species, Atopobium vaginae, and Prevotella. How do we know Gardnerella isn't the sole cause? Because this statistic tells us approximately 50% of asymptomatic sexually active women are colonized with Gardnerella vaginalis. Its presence is common. The dysbiosis it helps create is the problem. As you're examining that wet mount, pay attention to the background. In uncomplicated bacterial vaginosis, you see clue cells and a relative lack of inflammatory cells, the polymorphonuclear leukocytes, or polys. If you see numerous polys, consider it a red flag. This is not typical for simple bacterial vaginosis and should make you suspect a coexisting infection, such as cervicitis from chlamydia or gonorrhea, that requires a different investigation and management strategy. In our investigation, we also consider risk factors. One notable and evidence-based association is with the use of copper intrauterine devices. Women with copper intrauterine devices have a higher prevalence of bacterial vaginosis. The mechanism isn't fully clear but may relate to increased menstrual bleeding or a local inflammatory effect that disrupts the vaginal flora. It's an important piece of history to elicit. So, how do we treat this dysbiosis? Our first-line arsenals are well established. We have oral metronidazole for 7 days, which is highly effective. We also have intravaginal options: metronidazole gel for 5 days or clindamycin cream for 7 nights. These topical options minimize systemic side effects. Now, listen carefully to this crucial note. You might recall a single 2-gram dose of metronidazole for trichomoniasis. Do not use that regimen for bacterial vaginosis. It has unacceptably high failure rates for this polymicrobial condition. The longer courses are essential for ecological restoration. For patients who can't tolerate or fail first-line therapy, we have alternatives. Tinidazole, a drug similar to metronidazole, which can be given as 2 grams daily by mouth once a day for 2 days, or 1 gram daily by mouth once a day for 5 days. Oral clindamycin is another effective systemic option for 7 days, with a dose of 300 milligrams every 12 hours. For a shorter intravaginal course, we have clindamycin ovules, 100 milligrams, inserted for just 3 nights. Now, the warning is for patient safety and effective counseling. Clindamycin ovules use an oil-based carrier. This oil can weaken latex and rubber products within hours. This includes condoms and vaginal diaphragms. For the entire treatment period and for several days after, these contraceptive methods may be unreliable. You must counsel your patients to use an alternative, non-barrier form of contraception during this time to prevent both pregnancy and sexually transmitted infection. To conclude, let's zoom out. Bacterial vaginosis is more than just Gardnerella vaginalis. It is a complex shift in an ecosystem, represented by this consortium of bacteria and the elevated pH. Our diagnosis hinges on the practical finding of the clue cell, but our understanding must be deeper. We are not simply eradicating one bug. We are attempting to reset a microenvironment. Recognizing this synergy between Gardnerella, Mobiluncus, Adipobium, and others is the true key to effectively resolving this common clinical picture. Thank you. Don't forget to hit the like button and subscribe.